Great. So, welcome to our webinar, which is specifically for the Stickler community. If this is your first time participating in one of our events, we welcome you with open arms. As you know, today's presenters will address the hearing issues in Stickler syndrome and will answer your questions. Please put them in the Q&A box, not the chat box, and keep them general rather than sharing personal medical information. If your questions are not answered, you'll be able to submit them to our Help and Resource Center, and Stephanie, the nurse that we have there, will answer those along with her team, and we'll put that URL up for you a little bit later. So before we get started, I want to introduce you to our President and CEO, Michael Weimer, who's here just to say a couple of words and to say hello to you guys.
Thanks, Eileen. Good evening, everybody. It's nice to be back at another Stickler moment. I think we had our first kind of formal gathering of members of the community when we were in Atlanta this summer for conference. We had a dinner. We have a picture of the dinner. How about that? Wasn't aware of that, but it was nice to get so many family members together and do some cross-pollinating, building of new relationships, and more and more programming will now be coming out of the foundation as the Stickler movement continues to pick up momentum. We'll be virtual this year, June 15 to June 20. Will be the virtual conference. My guess is Eileen may mention that, but it will be a good opportunity for those that don't typically travel to conferences, and typically over a couple thousand people register globally for that event. So you'll see lots of announcements about that, and I think the more we can help the community, the better. We now have Marfan, Loeys-Dietz, vascular Ehlers-Danlos syndrome, VEDS, and with Stickler, there's lots of opportunity to continue to support your mission, and it fits very nicely with what we do here at the foundation as well. I'm easy to find, mweimer@marfan.org. So if you have ideas, suggestions, would like to chat about something, never hesitate to reach out. And with that, I'll kick it back to Eileen.
Yeah, thanks so much, Michael. And just to reinforce what Michael's talking about with the programs and services that we want to do for you, we do want to hear from you and we want your input. We like to share stories about people in the community, which helps other people learn how to live with the conditions that they have. So we do want to get to know you and we want to hear what your concerns are. And we have great doctors like Dr. Goudy, who is connecting us with other specialists in the area so that we can find the people who have the answers and the information for you guys. So, without further ado, let me talk about our speakers for tonight. Oops, there we go. Doesn't likes that picture better. Okay. Dr. Steve Goudy is the chair of otolaryngology at Old Dominion University in Virginia. He just joined Old Dominion this year from Emory, where he served as professor of otolaryngology and director of pediatric otolaryngology, as well as chief of pediatric otolaryngology, which I'm learning how to say very well now, at Children's Healthcare of Atlanta. Over the past decade, Dr. Goudy built the largest pediatric ENT division in the southeastern U.S. and developed 6 multidisciplinary clinics that bridge adult and pediatric care. His accomplishments in research and medical education are equally impressive. Dr. Goudy is also president-elect of the American Cleft Palate Association, and as I mentioned, has a lot of great connections that he's really helping us with so we can better serve you all. Elizabeth West is a pediatric audiologist at Vanderbilt University Medical Center in Nashville. She also serves as the Audiology Representative on Vanderbilt's Cleft and Craniofacial team. Liz is an experienced and knowledgeable clinician with specializations in newborn hearing disorders, complex care, electrophysiology testing, and cleft and craniofacial disorders. So I understand the two of them are going to sort of present together. So I'm going to shut my PowerPoint off and pass it over to them.
Great, Liz. I'm going to let you go ahead and share.
Okay, that sounds good.
Oh,
It requested
yes,
you, I
you got, yep, you're in.
Okay, great. I think it's working.
No, we don't see it yet.
Oh, not yet.
You work on it, Liz. from the American Cleft Palate Association perspective, I am now Eileen, since the last time we talked, I am actually the president. So
Right.
this is this is an important time to kind of highlight the work that the American Cleft Palate Association does and advocates for all families of children that have cleft and craniofacial differences. And so a lot of here we're going to talk about the audiologic perspectives as it relates to Stickler syndrome and more broadly cleft and craniofacial concerns. But if you have any questions, you can also access their website. Hopefully, Eileen, at some point will have backlinks between the two so that everybody
Yes.
can get all those, because there's standards, and I guess it's a long way of saying you should be treated by people that know and have heard of Stickler syndrome and understand what the standards are. And that's basically what Liz and I are going to discuss with you. There are some specific things with Stickler syndrome, but a lot of what we're going to focus on is what you should expect from anybody that's treating anybody anybody with a cleft and craniofacial difference. So,
Yeah.
and
Okay,
Liz,
guys.
and Liz, you're on a committee at the ACPA. You and I spent time together last night.
Yes.
So, tell
Yes.
everybody what committee you're on.
Yes, I'm on the ACPA Experience Committee, and last year I was on the program task force. So lots of different groups there that I'm getting involved with, thanks to Dr. Goudy. And I've been a part of ACA for quite some time now. I was on the cleft and craniofacial team before I came to Vanderbilt when I was a part of Wake Forest organization. And it's just been a delight, and getting to get more involved has been great.
Yeah, and now we're going to be very involved in the Marfan
That's
Foundation,
right.
right, Eileen?
Dynamic duo.
Right. Okay. Well, take it away.
All right, guys. So we're going to talk about the hearing portion of Stickler syndrome tonight. And I wanted to just give a brief overview because, interestingly enough, hearing is one of the least researched components of Stickler syndrome. So we have an occurrence of around 63% of patients. It is actually expected to probably be a higher number than that, but the current literature shows us 63% of patients with Stickler syndrome will experience hearing loss. The type of Stickler and the gene affected, that is what will dictate your permanent hearing loss severity. And that happens at the inner ear, your cochlea. And then there's also going to be some temporary fluctuating hearing loss we can experience. And that would be secondary to our eustachian tube dysfunction and congestion that can occur. And Dr. Goudy will definitely talk more about that. And when we have cleft palate, that also can create more of a long-standing eustachian tube dysfunction. So before we get into the weeds of Stickler types and hearing loss, I want to talk about just the severity of hearing loss. And when we look at different types, there will be different levels. So we have to have a good understanding of what we're actually measuring here and looking at. So this graph, if your children or you have a Stickler and have been diagnosed with hearing loss, then you may be familiar with this, but I'm going to start as if no one has ever seen it before. Top to bottom, that is, as you see, starting at normal hearing, going down in different severity levels: mild, moderate, moderately severe, severe, profound range. Left to right, that is pitch. So think of a deep bass key on your piano, and as you travel from left to right, you actually go up to treble keys. So we're testing deep, low bass sounds, usually are vowels, all the way to the high-pitched squeaky sounds, usually are consonants. Our mild to moderately severe range is typically hearing aid range. And then as we go into moderately severe to profound range for cochlear hearing loss, it would be more of your cochlear implant candidacy. And we'll talk about the types of amplification later on. There are three main types of Stickler, and how it presents with hearing loss is more in the mild range. So type 1, 52% of patients are typically reported with hearing loss. And that's usually in the higher pitches. So if we go back a little bit, we see those really quiet speech phonemes such as t, sh sounds Our newborn hearing screen does not always pick up on that type of hearing loss because, interestingly enough, we measure in a mild hearing loss range for newborn hearing. So sometimes we know this occurs in childhood, but we don't know exactly if it was congenital or if it was progressive in early childhood. Type 2 and 3, we actually see in a 69 to 83% hearing loss range reported. And that is typically a mild to moderate low frequency loss. And as we travel to our higher frequencies, is more in a moderate to severe range. This is typically caught at a younger age compared to type 1 because of the progression, the worsening of hearing throughout childhood that's been documented, as well as that severity range is just a little bit worse. So we're able to pick up on that at the time of the newborn hearing screen as well. Stickler 4 through 6, that's our rare types, but they do have the most severe type of hearing loss. It is typically going into a profound high frequency range with a mild to moderate low frequency range. Some forms are more progressive between 4 to 6, depending on the genetic expression. And then there are rare types of presentations in our genes that look like Stickler, but they are really case studies reported. So those have human and animal data, but not enough to group them like our 1 through 6 types. So why this is all important from a hearing standpoint is the earlier we catch hearing loss, the better. So we follow a guideline. It's kind of our audiology and ENT Bible of the Joint Committee of Infant Hearing. And that states by 1 month of age, every child should have a newborn hearing screen. By 2 to 3 months of age, every child should have a diagnostic test giving them advanced hearing data. And then by 3 to 6 months of age, we should have interventions in place that's going to give a child best prognosis for hearing loss. So what intervention means is if we have a hearing diagnosis, we need to know if they're going to be a hearing aid candidate and fit with those hearing aids by that age. Or if they're a cochlear implant candidate, we need to have them with their appropriate pathway lined up. Sometimes kids require other types of listening and auditory plans, and we'll get into that as well when we talk about the types of amplification. But children with congenital hearing loss or hearing loss in early childhood have tons of research has shown that their best speech development, communication, literacy, learning, psychosocial, it's all best if it's identified as early as possible. And for children who are born with normal hearing but have a progressive loss, the earlier we identify those children as well, the better. Where we kind of come into play as a team, audiologist and ENT. I'm a healthcare professional with a doctorate that specializes in prevention, identification, diagnosis, and evidence-based treatment of hearing balance and other auditory disorders. And Dr. Goudy, he is an ENT physician who specializes in the medical and surgical treatment for disorders of the ear, nose, and throat and related head and neck structures. So between the two of us and every audiologist and ENT team you'll meet, we have to work very closely together to identify what we're hearing in the appropriate intervention plan. This is important language, I think, for parents to know because even our medical partners can use these terms incorrectly. A newborn hearing screen only happens one time at birth. So when a child fails a newborn hearing screen, what happens after that is through an audiologist and its diagnostic testing. As I alluded to before, a newborn hearing screen is just that. It's at a very soft level and only one kind of presentation level. So we're not doing all the different speech phonemes and seeing where the hearing loss is breaking down, if it's temporary. It can't tell us any of that information. So typically, just because of the volume of newborn births, we have automated equipment where hopefully audiologists have trained technicians or which can be nurses or just hired on newborn techs. And they set up the equipment the way an audiologist would, but it actually is an automated algorithm that is running on the computer that passes or fails a baby. There are caveats to that. For example, Vanderbilt, my program, we started up making sure audiologists, they're actually doing a non-automated screen in the NICU, because we know our NICU babies have more complex care and are more prone to things like syndromes that would require us to actually analyze their auditory pathway and lower brainstem response. So we want to make sure if there's anything present, or anything abnormal, we're the ones identifying it and not leaving it to a computer system. Diagnostic testing happens after a failed screen, or if there's any sort of risk factors that would require a child to have more testing beyond the screen. That can look like physical differences. So our microtia, atresia, when we're missing parts of our outer ear or ear canal, a lot of times those babies go straight to a diagnostic test. If we know they have a syndrome associated with hearing loss, we should be doing diagnostic testing right after the screen. But this is only performed by audiologists. And again, we're assessing the whole speech spectrum, not just that kind of targeted area of our cochlea. When we say diagnostic testing, we mean usually an auditory brainstem response test. If you guys have seen that, that's where we're setting up electrodes, putting inserts in the ear, and the baby has to either be asleep, or a child or participant has to be sedated or in a natural sleep state for us to be able to get accurate readings from their lower brainstem, auditory nerve, and cochlea. We also do something called OAEs, and that's looking just at the peripheral part of your organ. It can't tell us all the information an ABR can, but it does add to our test battery, where if those responses are present, we can usually indicate some good hearing, at least at part of the cochlea. And then as we travel more towards the inner ear and auditory nerve, we would need the ABR to help identify any sort of hearing issues there. Tympanometry is what audiologists use when we're trying to assess if there's any sort of fluid, congestion, or eustachian tube problems happening. It also can pick up on any congenital anomalies with maybe our ossicles that were not formed correctly, or we have hypercompliance of our eardrums. So that's a test that just helps us know if we're measuring a hearing issue, is there also a contributing factor that's happening behind our eardrum and our middle ear space? And then otoscopy is when we are looking at the whole outer ear, so the pinna, the outer ear portion, and then into the middle, the ear canal up to the eardrum. So signs of hearing loss, this is going to vary based off of the severity of the hearing loss a person or child may have, and their age and developmental skills. So I'm speaking of typically developing children when I speak of these sort of signs of hearing loss. So in a toddler, if they have a profound hearing loss, which in layman terms we would consider deafness, they would have a complete lack of startle. When we have more mild to moderate hearing losses, they can hear you, but maybe it's not until you get closer in proximity. They could be non-responsive to certain speech sounds or speakers in their environment, depending on how close the speaker is or if there's background noise present. They could have difficulty localizing. If we have one good ear and one bad one, they could turn easily to this side, but if they even perceive sound on their bad side, they could turn to their good hearing ear because that other ear has been void of sound. They could have minimal development or no development in their speech, and overall developmental milestones. When we're talking about children, if they've already acquired speech, they could start having articulation disorders. They could have delayed speech, depending on the timing of their hearing loss. They could have difficulty following directions, requiring repetition, increased volume of their iPads, televisions. They could have frustration when trying to express themselves, exhaustion, especially in school. There's tons of research that a colleague of mine has done with listening fatigue. So children who have hearing loss and it's not diagnosed, or they don't have appropriate interventions in place, they can really struggle to hear all parts of speech, and that can make them fall behind academically. We want to monitor kids with normal hearing that have any syndrome associated with hearing loss, such as Stickler. And we want to do that at least every 6 months if we're continually continuously measuring normal hearing. If we have hearing loss at Vanderbilt, our protocol that I helped develop is at least every 3 months until they're a little bit older and we've had many tests showing stable results, and then we'll push out to 6 months. Treatment of hearing loss, from my standpoint, would be amplification. So your audiologists are going to be the ones fitting you with the hearing aids, mapping your cochlear implants, helping you with assistive listening technology. That can be FM systems in the school. That can also be remote mics for parents who are at home with their kids and want to give them direct sound, even if they're not face-to-face. Strategical seating, which is we want to make sure whatever the classroom setup is, your child or you are in the best possible place to be hearing all the information with visual cues and where your hearing aids or assistive listening technology is doing its best. Our ENT partners come in and they help us with our surgical interventions and whole medical workup of a child. So Dr. Goudy will talk about this momentarily, but PE tubes, our cochlear implantation surgeries, medical clearance for hearing aids, and anatomical correction of hearing. This is just nice little examples of visuals. There's too many to put on here at this point. But this is to the left is a child in a traditional hearing aid, so an ear mold coupled to a hearing aid. Our little ones have to have ear molds because as they grow, their ears are growing nonstop, and we can't just put a little tube in and hope the hearing aid stays in there. So as they get older, we can visit technology that is more discreet, but we have to have those ear molds made every couple of months as they grow. To our bottom right, you see a cochlear implant user. And then these are the different types of FM systems. We have pen systems that can be speaker systems that are passed around from let's say it's a group discussion, which I know is very common now, not just the teacher speaking in these educational situations. So they can pass it around to the speakers. We have a remote mic at the top here where a teacher will wear it or the desired speaker will wear it, and it will stream right to a processor. And we also have speaker desk systems. Some schools may not have the budget for a lot of these high-tech FM systems that are very costly. So they can actually do speaker systems to help with that signal to noise ratio from the teacher to the child. And you can take it away, Steve.
Great. I was Liz, if you can look through the chat or the Q&A rather, there's a lot of different questions, and some related to auditory neuropathy, progressive hearing loss, and so on. So take a look at that, and then maybe you and I can just kind of chat about our perspectives. So one question that I fielded related to ear tubes, and do you mind going back to
Yes, I'm getting right back. Sorry.
Yeah, no, you're good. So eustachian tube dysfunction is very common in patients that have Stickler syndrome. Many patients that have Stickler syndrome also have a cleft palate. They also may have PRO band sequence, which is neonatal airway obstruction or neonatal sleep apnea, basically. And so we may not be able to identify, whether they have, hearing challenges or fluid behind their ears or whatever for a while. Particularly if you have bad airway, the airway kind of trumps everything else. And as Liz said, I mean, some babies end up in the NICU for months and months, and so certainly you all are likely very aware of that. But those kinds of things of airway issues and so on will oftentimes kind of trump whether or not we're getting to the bottom of the hearing situation. But the majority of babies that have a cleft palate will have eustachian tube dysfunction. And your eustachian tube, and Liz showed you a picture of it earlier, it's the tube that pops your ear. So when you go over a mountain or a plane, you swallow, you chew gum, the muscles in your palate, which is the roof of your mouth, they pull on each other and then they pop your ears. And so obviously, if your child has a cleft palate, those muscles aren't all the way together, so fluid builds up. And so Liz or one of her colleagues is going to go to the NICU. Your child has been there potentially for some time, and your child is going to refer on their hearing test because the fluid sometimes will interfere with the test, whether it's an OAE or a screening ABR, and the NICU is a loud and noisy place. So as simple as ear tubes seem, many times Liz and I may kind of have a conversation, say, hey, well, this baby is referred, the genetics for Stickler takes a long time to come back, but, if they do have Stickler syndrome, I personally feel very strongly that they should not leave the NICU without a diagnosis. And so the diagnosis may involve a trip to the OR to put ear tubes in, even at 2 or 3 months of age, because of the fluid, and a diagnostic auditory brainstem response test. And so, here is a picture. You can see there's a tiny little blue tube. It holds a hole in the eardrum, lets the fluid drain out. In the OR, I put that in. It takes me 15 minutes to do, and then Liz or her colleagues can do the diagnostic auditory brainstem response test in the OR. And that takes about an hour-ish. If there's hearing loss, it may take longer. Life with ear tubes is pretty straightforward. You can swim, no lakes, no ponds, no oceans. In my opinion, this is just my opinion, that people may tell you different things. But either way, if your child has Stickler syndrome, you need to be seeing a pediatric otolaryngologist or somebody else that specializes in hearing loss. As and Eileen put in the chat, the Cleft Palate Association has a list of teams. The teams have to have the whole team together. Your child deserves patient-centered care. So that's not just, me, not just Liz, but it's a speech pathologist, maybe it's a dentist, there's a whole lot of people that need to surround and support your child. So, I'm going to put ear tubes in if Liz tells me to, number one, or number two, if your child has fluid for 3 months or longer, because that's going to cause a conductive hearing loss. It's like when you have a bad cold and you fly on a plane, you're like, I can't hear anything, right? Your kid is actually, it's worse than that, right? It's a conductive hearing loss. So conductive means the amplification system of your ear canal, eardrum is not working as well. And so that can be fluid, but it can also be, related to the little inner ear bones, or the ligaments. So Stickler syndrome is a collagen, in many cases, a difference in the way that collagen is made. And so collagen really is a precursor for many of the things in the middle ear. And so that's just one thing as it relates to ear tubes. Somebody asked, could the progressive hearing loss or the hearing loss that either they or their child had be related to the ear tubes? The short answer is probably not. As Liz went over, and we can kind of talk about this a little bit more if you want to put your questions in the chat, is that, and Liz and I were kind of in preparing for this talk, we're talking about is like, okay, even if Liz does a diagnostic ABR, that doesn't mean that your child is going to hear the same way over their lifetime. And so that's why she mentioned that there will need to be ongoing screening at 3 to 6 month intervals, depending on, what the genetic difference that your child may have. So that, it's a complicated decision, and it requires interdisciplinary care, meaning that your ENT and your audiologist are in the same office having a conversation, and we as a group are having conversation with your teachers, with the other doctors, and so on. So let's go to the next slide. So we talked a lot about this. So, the purpose of the tubes is to drain the fluid or, prevent infections. I mean, the two reasons that we discussed to get ear tubes are fluid that's present for 3 months or longer, and or concern for causing hearing loss. And once you drain the fluid, that part of the hearing will get better. If the little ear bones, the malleus, the incus, and the stapes don't work as well, that's not going to get any better. But if the fluid is the problem, should resolve it. They can go swimming. The tubes stay in for about a year, and then they should fall out. If they fall out, again, that's why we're repeat testing. So Liz will see, I'll see you every 6 months because you have ear tubes. And at the same time, if you're young and you're not tracking on your speech, right? Because it really is holistic, because your child isn't going to be able to raise his hand to say, yes, I hear that. No, I don't. Liz is in the booth trying to uh, cajole these wild children to localize their hearing, right? And some of the patients that have Stickler syndrome will have progressive but very mild and very high frequency hearing loss. So that's really hard to detect in a 2-year-old boy or girl. So it really is a combined approach, and that's why having a patient-centered approach makes sense. On average, patients that have a cleft palate will need about 3 sets of ear tubes in their lifetime. Sometimes it just takes a while for their muscles or the eustachian tube to kind of work, and usually that's around 6 or 7 years of age. But some patients, cleft and non-cleft, will need ear tubes for their whole life. So you may end up needing to see an ENT for a long, long time. The other thing, just caveat, this is a soapbox unrelated to ears or hearing, but if your child does have Stickler syndrome and has had a cleft palate, they shouldn't get their adenoids removed unless people have thought very carefully about that. That's something that we do very frequently in a non-cleft population, but because the palate is short, potentially, if you move the adenoids, which are at the back of the nose, then you can make their speech worse by taking out their adenoids in an attempt that you're trying to normalize their ear function. Long term, there are some other things that are coming on the market now around, to try to mitigate the need for ear tubes for the rest of your life, called eustachian tube dilation, where we can actually put a camera in the back of the nose, go up through the eustachian tube and stretch it out. That's not for tiny babies. That would be for teenagers. And then we talked about the routine speech screening and therapy. Do we have other slides or no? I can't remember.
I think it was just our summary.
Yeah. Why don't you give the summary and then I'll look at some of
Sure.
these other questions.
Yeah, and I apologize when I share my screen, it's not letting me look at the chat. So as soon as I look at this, I'll be able to read the chat
Well,
too.
Let me just interrupt for 1 second. Since you guys have this one summary slide, why don't you hold on the questions, then you can answer them live so everybody can hear them. So,
Okay,
because
sounds
that's
good.
great what you've been doing, but this way everybody else can benefit as well.
Awesome. So just go over this and then I can hop off and then we can do the questions.
Oh,
Okay.
yeah, or I can read them to you. Why don't you go ahead?
Okay, I'll just wrap everything up that we were talking about. So our summary of this is hearing needs to be closely monitored in children with Stickler. And again, as I said at the very beginning, even the research admits that hearing is kind of the least documented part of Stickler syndrome. And so we are hoping that in the future there will be more data where more people are testing earlier and we can actually know if the types are, if they're present at birth, congenital, or if it's progressive, how quickly is that progressing? Newborn hearing screen cannot catch all hearing loss present at birth. So a diagnostic test by your audiologist should be performed as soon as possible if you know your child has a syndrome associated with hearing loss. An ENT physician should establish care with the patient ASAP due to their high risk for hearing loss and eustachian tube dysfunction. Hearing should be monitored closely throughout childhood to identify any changes quickly and implement appropriate interventions. And there are many types of amplification available to help improve hearing status when a hearing loss is present.
All right. Let's just go back through the beginning question. I'm going to go through some of them. The first one, with the fact that as a child having ear tubes inserted for ear infection be correlated with progressive hearing loss. And we did answer this, or at least I did. I don't know. The one caveat I meant to say, you really need to be thoughtful about the type of eardrops that you put in your child's ear. I mean, by and large now, the majority of people know that you should really only put in floxin or ofloxacin and Ciprodex drops in your child's ear. Occasionally we might use something else, but some of the medicines that are used for swimmer's ear or other problems can be what's called ototoxic, meaning it will ruin your hearing. So just being thoughtful about that is important. But in general, the tubes are not going to be what is causing progressive hearing loss. Progressive hearing loss is the underlying genetic diagnosis, and we don't really have great ways to determine where the exact issue is in the cochlea. There's not really much in the literature about that, whether it's a change in the cochlea And it may be interesting, Liz. I mean, there's a different genetic process. It's not Stickler syndrome, but there's a different genetic process called otophyllin where they have progressive hearing loss. And now people are actually rescuing that hearing loss through delivery of a virus that produces the normal protein. So I don't know if it's relevant in this scenario, or I know it's not relevant right now, but will it be relevant in the future? I'm not sure.
Yeah, the auditory neuropathy question, it is not a newer form of hearing loss. It's just now finally being more understood by the general medical population as well as parents. Neuropathy there's no correlation with that with Stickler. Auditory neuropathy, or there are two types of retrocochlear hearing losses. So our inner ear, that's our sensory kind of portion of our hearing loss. And then we go up past the inner ear and we're past the cochlea and we're in the auditory nerve, lower brain stem. So auditory neuropathy is when our organ of hearing can hear and it can take all those sounds, but it cannot send it up consistently to our auditory nerve and lower brain stem. So think of a radio, a dial, a very clear channel, you're hearing everything, the melody, the lyrics. But if your station's going in and out, you're not getting consistent sound. You're not getting consistent speech stimuli that's going to be able for you to be able to replicate that as you're growing and developing. So that's how I describe neuropathy to patients. And it's usually a different kind of genetic disorder, or we have some sort of neurological diagnosis, their bigger medical picture. An example is hypoxic ischemic encephalopathy. Like we have a lot of those kids who can have neuropathy. We have kids who had a high bilirubin requiring exchange transfusions in very medical complex babies. So that can create neuropathy, but it's basically anything that can happen beyond your cochlea. And it's not related to Stickler, to our knowledge. I've not seen anything anecdotally in clinic or in the research showing that. So I hope that helps with that question. And then the instruments and music, Steve answered appropriately. Yes, it depends on where their hearing loss is and the severity. So as long as they're appropriately amplified, they will have access to music. There is a different, how we're hearing right now is through our whole auditory system that's not impaired. When we have an impaired auditory system, giving them hearing aids or cochlear implants does give them access. But as Steve really harped on, we need interdisciplinary care with speech pathologists because your brain has to learn how to hear that signal now through a mechanical or an electrical acoustic input. So their hearing aid is amplifying, but they need to be with a speech therapist who's tracking and monitoring their progress and their speech and development. So I hope that answers that. And then
And I think we talked, I mean, maybe kind of double click on the progressive, like how you
the
get to the
progressive
bottom.
one,
Yeah,
yeah.
I think progressive is because that is what we see in this patient population and how these
Mhm.
families need to be armed. Because my guess is many of you are seeing people that don't see Stickler, or patients with Stickler very often. And so they're not going to know that it's progressive, and
Right.
you need to stay on them. Because if
Yeah,
just because it's normal doesn't, mean it's always going to be normal.
correct. And the types are going to be a little bit dependent on that. So our 1 through 3 types, type 1 is the main one, and that's the mild hearing loss. That one actually has enough research to show at some point in childhood, whether it's congenital or early childhood, it is present. When it's talking about progression, it did not show a lot of literature that our kids who are teenage years and adult years are showing progressive beyond a mild loss for that type 1. Type 2 and 3 does have more progression. And then our 4 through 6, that's already at a level that might be considering cochlear implant candidacy. So if they start out in hearing aids, that would be severity of hearing loss where we would start looking at cochlear implants due to progression. So it's dependent on type, and your audiologist really, for me, not even with Stickler. If I have a child with hearing loss, we always replicate their results within 2 months time. We usually say 4 to 6 weeks, so a month to 2 months. If those results stay stable, then it's 3 months. And then I'm looking at them every 3 months unless they let me know their pediatrician said they had an ear infection. I'm bringing them in sooner because if they have now ear infection on top of permanent hearing loss, we're going to have worse hearing thresholds and our hearing aids won't be set appropriately. So we are doing very close monitoring over their whole picture. We have tons of kids who go home, from the hospital if they were in our NICU and they get readmitted for something else that could cause worse hearing. So making sure your audiologist and your ENT is well programmed into your whole medical team. That will be the most important for monitoring signs of progression.
Liz, I wanted to just jump in because there's one other question related to this that's open. And you talked about progression related to the different types, but is there any data to show any correlation with growth spurts?
Not growth spurts that
Right.
I've
Okay.
seen, no. That's a great question. I don't think, from what I found, there was not a lot of data on that.
The one thing I would say that I think Liz covered, but again, as families, these children they have a lot of different things going on, and it's hard to balance, particularly if you don't live, even if you live in a city that has a major, medical center and a team that's focused on this, that there's a finite window of time that you have to access the plasticity of the brain. And what does that mean? That means that, you have, I wouldn't say, I mean, it's a ticking, it's not a time bomb, but I mean, it's a race, right? Like the sooner you identify this, the sooner you get it intervened, whether it's hearing aids, cochlear implants, or whatever, the better your child will be. And those, I mean, those are choices that you have to make, but you really need to get the data and you really need to push people, particularly if your intuition, is telling you there's a problem, then there probably is a problem, right? And if you're not being taken seriously, you need to find other people that can take you seriously. Um, just because, unfortunately, we will see some of these patients that don't get diagnosed for a year and a half, and they're very far behind the access, of sound, which means the access of speech, and there's lots of studies to correlate like how you're able to access sound and how you're able to access speech will determine what you can go and do and become for the rest of your life, and we can go, I mean, that's my soapbox, so thank you for coming to my TED Talk, but it's really, really important.
Yeah. I will say too on that, I tell my families of little ones and with a mild to moderate hearing loss, it is so, a lot of times these babies could be in the NICU and they have so much going on, and then you just add hearing to the mix and it feels like too much. So even NICU or not, complex care or not, a mild and moderate hearing loss in a child can be in an infant can be almost an invisible disease. So a lot of times they're relying on vision and other sensory inputs such as touch. And it's hard when we're telling you keep these hearing aids on them. We're measuring hearing loss, but you're not seeing it because you walk in a room and they turn to you or they respond to your voice. It is because unless a child is fully hearing impaired, profound deafness, they are going to hear part of your voice and they are going to turn to part of your voice and they are going to interact with you and smile at you. And all of that is true. It is also true they're not hearing the whole speech spectrum. So if they're not hearing that from early age, it's not going to do them any good to be listening to muffled sound. And then we expect them to replicate those speech sounds. We already are going to have challenges with children with craniofacial disorders such as cleft palate because your articulation is going to be a struggle because your structures are not fully formed the way they should have been. So if we're dealing with language now on top of articulation, we're just stacking the cards against them. And that's why I really harp to my families, hey, mild hearing loss, moderate hearing loss, it's present and you won't notice it until it's a little bit too late. So just trust us that these devices and this intervention plan that your doctors have come up with is the correct one to give them best long-term outcomes.
Yeah, and I just want to reiterate what Liz said. Number one, I mean, you're counting on sight, but somebody put in the chat like, hey, I mean, because patients that have Stickler, may also have vision differences,
Yes.
right? Number one, like 100% of the time, I want to know the genetic diagnosis because it's not just related to, it tells me more information, right? Like I obviously screening for eye issues. If your child has Pierre band sequence, you need to get them screened for Stickler. I mean, I assume that we're kind of preaching to the choir here, but if somebody's watching this and if their child had Pierre band sequence, they need to be evaluated for Stickler. And then with the diagnosis of Stickler, then we get the eye doctors involved, we have the audiologists involved, and again, if you have a multi-sensory challenge or difference, that's going to also really impact what you can do and where you can go and as it relates to school and services. And the earlier you habituate your child to hearing aids, the easier it is. I mean, you can't get a 2-year-old to blow their nose, much less leave a hearing aid on. And if they've enjoyed, I mean, I wouldn't say enjoy, but if they have grown to expect quiet, and then all of a sudden you're amplifying everything around them, then that's really going to be disturbing to them, and they're not going to want it. So I think there's lots of things. I'm going to go back and talk about the adenoid thing. I did not do a good job of explaining that. So the adenoids are a tissue at the back of your nose. So if you can stick your finger all the way to the back of your nose, that's where the adenoids are. That's like the tonsils, but in your nose. It's adjacent to, meaning right next to the eustachian tube. So as an ENT doctor, typically for the second set of ear tubes, I'm going to take out the adenoids on the majority of patients because there's a paper that suggested that reduces the need for a third set of ear tubes. However, in patients that have a cleft palate or Stickler, what have you, I'm less likely to do that because then it may cause some, speech issues. The tonsils, I don't worry about taking the tonsil. I mean, you're not going to take the tonsils out for ear problems per se, but if you need to take the tonsils out in a patient that's had a cleft palate repair, that's not as big of a concern. Liz, there's a question. Anything on the horizon regarding tools to slow the progression? I guess the progression of hearing loss, my guess would be probably not. I mean, I think maybe Liz, if you can talk about noise exposure and how you counsel families whose children have hearing loss about noise exposure, ototoxicity, any kind of, not make a bad thing worse kind of thing.
Right, yeah. There is currently no plan for helping progressive hearing loss. There is some genetic testing going around, as Steve mentioned, of we are successfully in some ways helping improve or cure hearing loss, but it's a very specific gene that's not related to Stickler. Yes, volume control on your children's tablets, that's the number one thing I show families, here's where you can lock this, where they cannot get louder. We also, with hearing aids, anything they can stream through hearing aids, they should do. Your hearing aid should be set by a pediatric audiologist who's doing two things. One, taking the gain of every single frequency and putting in a prescription that is correlated with their ear canal size. That's so important for pediatric fittings because most equipment is calibrated to adult. So if we are putting a prescription in for a severe hearing loss and then using the adult length of an ear canal, the sound pressure level is just going to over amplify them and cause more hearing damage. So it is so important your children and yourself, actually, even adults, that you guys are going to audiologists who perform verification measures. And you will know, you can ask them, they usually stick a probe in the ear. You either hear a carrot story or another type of story, or it's in a test box. You'll know that they're doing that. And then I saw also progressive hearing loss in adults. Full disclosure, I haven't tested an adult since I was in grad school. But if I can talk about progressive hearing loss in general, if you have a specific question about it, there is still no data to slow down that progression either. And the same thing for children goes for adults. We want to be very mindful of not over amplifying, of wearing hearing protection. If you're going to concerts, loud events, even if you're hearing impaired, you still have usable hearing. Unless you have a cochlear implant, then you can just take it off. But we definitely want to be practicing safe hearing with earplugs, and you can get custom molds made, or you can use the ones they give specs on Amazon, Target, of what they're actually occluding sound wise.
Yeah, I mean, I think the one thing that I can say is that all of the interventions and therapies for hearing loss that are on the horizon are sponsored in general by the NIH. So, writing to your congressperson saying, "Hey, we want to continue to develop therapies. We need to support research." And obviously Stickler. I mean, and Eileen, the Marfan, Foundation has research grants. So I think that there is an ecosystem. It's not just the NIH, but we can't help your children if we don't have ways in which to study it, to model it. Maybe, my hope would be that in 20 or 30 years, maybe there is some, something that you can get injected into your ear that would slow the progression. As far as tinnitus goes, the tinnitus, that's a challenging thing. There's something called tinnitus retraining, which, is really where you and your, and your audiologist or whoever helps you kind of reframe and treat the tinnitus. I mean, there's not any medicine that's going to make the tinnitus go away necessarily. There are some, medications, antidepressants, and so on that help people kind of, it doesn't become as overwhelming. Yeah, I mean, I agree. We need to help adults as well. I think, quite honestly, it's easier and more cost effective to bring therapies to adults than children. So yes, 100%. We need all the research to help all the people.
Yeah. And with tinnitus too, I see that you say your hearing aids, it's worse with them. That is rare. So I would ask for some more hearing aid programming with your audiologist. I'm sure they've looked into that, but usually even people with normal hearing, we sometimes will fit with hearing aids with tinnitus because it just helps deprive, if you even have minimal hearing loss, it helps give you extra sound and kind of helps that, it serves as a little bit of a distractor from that sound that's internal. When you have hearing loss, hearing aids can sometimes help because it's giving you back the sound that you were missing. So if that's not working by hearing aids alone, then yes, there's retraining therapy and also just sometimes talk therapy and psychosocial therapy helps with that because it can become so severe in patients that it can become a little bit of life-altering disability.
Thank you
Yeah.
so much. I mean, this was really great. I love the way you guys presented and then interacted with everybody. Really, really informative, and people got their questions answered. And just love your style. The two of you work so well together. So that was really great as our first hearing webinar. We're getting close to the end here. So I just wanted to let people know if they have more questions after this or something that they thought of they didn't get to ask. You can send that through our help center to marfan.org/ask. Stephanie and her team can answer it. If they don't have the answer, they will obviously talk to our two presenters today and other specialists that we work with to get your questions answered. Really, the best way is to go through that URL because they have a system there and they can go back and forth with you and help you with your specific questions. Also, after this webinar, watch for our email this week. We'll have a link to this recording. We'll have some other important links. Also, an evaluation form so that we can find out not only what you think about this webinar, but also what other topics you might want to cover, want us to cover rather. So we really do want to hear from you. In terms of our other Stickler offerings, we do have some basic information on Stickler on our website. We are fully aware that we need to do a lot more for you all. So just, keep your eye on this. We want to Also, make sure you're aware of other things on our website, our Walks for Victory, where they're community events and they're all over the country. And so you can get involved, meet other people. There are Marfan teams, Lois Dietz teams, Stickler teams. So it's a great way to be part of the community. And there's a lot coming up in the first several months of this year. So take a look at that. And we will have more Stickler focused webinars. So again, we want to hear from you. What are your questions? And we will surely do what we can do to find the specialists who can do these webinars and bring that information to you. If you're not getting our emails, I kind of think you are if you're on this webinar, but maybe you saw something about this on social media. So if you sign up for your preferences, you'll only get the Stickler emails. You won't be getting emails on 100 other things. So that's the link to the QR code that you can scan. It'll also be in the email that we send you. And yeah, again, make sure you say that you have Stickler on there, and this way you'll get what's specific to you. So again, we want to thank our speakers tonight and thank you for putting the time in for this and sharing your expertise with us. I'm looking forward to seeing you both in person sometime soon. And thank you everybody for coming tonight. And we do want to keep doing more for you, and we want to hear from you what you need. And we're here for you. You're not alone. So thank you, everybody, and thank you to our speakers.
Thank you guys for having us.
Okay, have a great night, everybody.
Bye, y'all.
Bye.